Thank you, everybody here in Louisiana. Thank you for coming to this program tonight. This is our very, very first program that we are doing in Louisiana, and we do hope to be on back to this area as well as Baton Rouge, Lafayette, and other places, because we do know how much these kinds of programs are needed. So we are using tonight as a test. All right? And we know that you all are going to learn greatly from this program. For tonight's program, and like all of our programs, we always get our dollars to do our programs from the pharmaceutical industry. And tonight we all hope that you all will appreciate as well. It's Heaven Neuroscience for giving us the funding to do tonight's program, and we hope that you could all thank them as well. So next up we have Dr. Bagert. Right? Come on down. I'll let you introduce yourself.
Thank you.
And Dr. Bagert's going to speak for 45 to 50 minutes. Okay?
Yeah.
And I'll give you 5 minutes. Okay. Good. Great. Perfect. Let's get started.
Okay. Well, thanks for coming tonight. What a great group. I know many familiar faces here. And I've got a few people from the MS Center here. And it's really great to speak for MS Views and News, which is something I've never done before. So this is, it's wonderful. It's driven by patients for patients. So I'm particularly excited about that. So I'm going to talk to you about a few something I've never talked about before, which is this concept of shared decision making. And this is an outline of the talk today. So we'll talk about this new idea, shared decision making, which we'll get into in a minute, and how to get your needs met in your relationship with your doctor or care provider. We'll talk very briefly about MS medication. I guess it's a good problem to have so many different MS medications available that we can't really just touch on it. It's almost impossible, but I will touch on it for a second. And then if there's specific questions afterwards, I'll be happy to take them. I want to talk a little bit about the future, some of the things that I find exciting right now on the horizon of MS. And then finally, a word about wellness, which I can't resist talking about. I wasn't asked to speak about it, but I just can't resist. Okay. So what is this idea of shared decision making? It's grounded in the concept of patient-centered care. And the goal of this idea is to shift the focus of healthcare providers away from the disease and back to the patient and their family. It's very commonplace when I go to the doctor too, for there to be just a focus on the MRI or the labs or the testing or the computer, and especially when you have MS and there's so many things to deal with, it can be very easy for that shift to happen. And this is true all around all of healthcare in every different disease state. And I think in the 90s, people started thinking about it and writing about it, saying, what's going on? Where's the patient in all of this chaos? And so people started writing and thinking about it. And in 2001, the Institute of Medicine came out with a position paper that they said, Crossing the Quality Chasm. And they define patient-centered care as care that's respectful of and responsive to individual patient preferences, needs, and values, and that ensures that patient values guide all clinical decisions. Sounds good, right? And patients and caregivers basically must work together. That's what this whole idea is about. Rather than the doctor lording over you in the clinic and making all the decisions for you, actually, it's a relationship, and it has to start with the patient, actually. This is what this idea is about. So what about shared decision-making in the world of multiple sclerosis when you have MS? Well, boy, the modern MS landscape is very complicated, getting more and more so literally every year. There's so many decisions to think about, and just a sampling, just a little brainstorm. First of all, whether or not I need treatment at all, a patient may ask, and that needs to be addressed. What immunotherapy of all the 15 now available should I use? Which one's best for me? Which And you have to think about, well, what kind of MS does the patient have? What's the effectiveness of that drug or all 15 drugs? What's the risk? What are the side effects and tolerability? What is the cost? How much surveillance testing am I going to have? Do I need an MRI every 6 months? Do I need blood work every month? What are the patient's goals? What's the patient's risk tolerance? These are things that really should be addressed for every patient. And so MS is really the best example of all of a condition where shared decision-making should happen in the clinic. So this is a schematic sort of depicting the idea of shared decision-making. And basically the patient drives all the interactions, and the patient's values inform the communication with the physician. So again, the patient's care partner or caregiver articulates values to the physician, and it results in shared decision-making in the context of clinical uncertainty. And it starts with soliciting patients' values, saying, what is it that your goal is? What do you want? I often ask new patients who come to the clinic, what are your goals? Why are you here? Not in a flippant way, in a sincere way. Like, what is it that you really want? What are you hoping for? Because I really want to know. Discussion of pros and cons of options. And at the end of the day, it's a personal decision for that patient. Here's the list of all the disease-modifying therapies, just to give you, just to remind you how darn complicated it is. So, right, it starts in 1993 and goes all the way to last month with ocrelizumab. It's 14, 15, I can't count. So there's a lot to consider these days in the MS clinic, and I guess it's a good problem to have, right? But the question is, how do we do it? All right, so decision aids. So decision aids are tools that patients can use to help educate them and guide them to these decisions. And all the big patient advocacy organizations have websites that help provide information that is generally accessible and easy to get on the internet. So this is just a snapshot, a screenshot of the MSAA, their page on disease-modifying therapies, right here. Here's a screenshot from MS Views and News on their list of all the different medications, and it goes a lot further down. And here's one from England called the MS Trust, and they actually are very sensitive to this idea that it is a decision guide. And they say, MS Decisions is a guide to the disease-modifying drugs approved for treating relapsing remitting multiple sclerosis. Each drug offers a different combination of benefits and risks. These web pages will help you explore your options and help you discuss starting or switching between one of the drugs. And it's sort of a very complicated website, very, very helpful. So it's called MS Trust, and it's online. So one of the things I was asked to talk about is, how do you get your needs met in the clinic? And of course, it's always very individual, but I think there are some guiding principles. First is to pick your care provider carefully. Sometimes that's easier said than done, right? Depending on where you live and how easy or difficult it is to get to a doctor or care provider. But I think it does matter. It shouldn't be a casual decision. I think you just need mostly to have someone who listens to you and cares. It's sort of the standard. I would recommend keeping a journal about your experiences and your symptoms, and when thoughts cross your mind, be ready. Prepare for your visit. Have your questions ready and organized. Bring a friend. It's always good to have another person with you, because it's, there's all this data that people in the clinic don't hear or remember everything that's said. To have another set of ears there is a good idea. Accept your own role in the decision, but be open to your provider's thoughts and input. Educate yourself as much as you can, maybe using decision aids or other vetted material. And then, this is important, be ready to express your values. What's important to me? What is your preference? Because for shared decision-making to work, you have to be engaged in the process. Excuse me. Know your worth. You deserve the best care, and it's okay to expect your provider's time and your provider's attention. But it's also important to be sensitive to limitations and just realities in the clinic. So if you're there and you really want to talk about new treatment, that's a detailed, long discussion. It's probably not a good idea to bring up some of your diabetes issues or, spend 10 minutes talking about things that are really not why you're there. I think it's important to be sensitive to realities, but it's also important to have high expectations for what you deserve and demand that you get them. Be willing to come back to clinic to continue the discussion if you need to. That's part of being engaged. Like, hey, you're willing, I'm willing. I'll see you in a few weeks. I'll think more about this. And then again, use the MS patient advocacy organizations and resources for those decision aids. Okay, so that's moving on to talking about disease-modifying therapy. And I'm really not going to spend much time on this at all. I'm just going to kind of give a brief overview and then talk about some of the newer things too that I find more exciting. So just by way of review, right, MS is a disorder of the immune system. It's the immune system that's out of balance, and there's excessive inflammation, which is basically white blood cells that gain the ability to cross that blood-brain barrier and enter the brain and cause damage, and they attack myelin and the central nervous system. We're in this new era of treatment for MS that began in the mid-90s and continues to this day, where the basic concepts are treat early, shift the disease as early as possible, consider the individual. There's no one-size-fits-all approach in multiple sclerosis because the disease is so tremendously variable from one individual to another. This is not ALS, this is not muscular dystrophy. It's tremendously variable and it requires an individual approach. And the goal of treatment is simply to prevent people from becoming disabled, and while also minimizing the risk of immunotherapy. So it's a balancing act. We could ablate everyone's immune system and prevent disability that way, but the risks would be unacceptable of doing that in general. So we're threading a needle a little bit. And the comprehensive care approach is the new standard of quality MS care. So I have all the medications over 2 slides, and it's in chronological order. Beta-serin came out in 1993, and followed by Avonex, and then Copaxone in the 90s. Mitoxantrone was approved in 2000. It's not used that much anymore because of a risk of leukemia later, but very effective, actually. I hear stories all the time about how that medicine really shut down people's MS and sort of changed the course. Rebif came out in 2002. Tysabri came out in 2006. And interferon beta Extavia, which is the same thing as beta-seron, came out in 2009. The interferons in general and Copaxone are what I consider to be more milder medications, not as powerful in general. However, for certain individuals, it's absolutely all they need. And that's the important concept, is that, when you look at data from clinical trials, they average relapse rate reduction. There's averages, and for some people it just didn't work at all, and for other people it shut the disease down. And that's what's important to remember. And for many, many people who take these platform therapies, it's enough to shut the disease down without exposing people to undue risk. Tysabri was really a revolutionary drug that we use a lot of. In fact, we use pretty much all of these medications in our clinic. It's a monthly medication. It blocks white blood cells from crossing the blood-brain barrier and is highly, highly effective in relapsing forms of MS, but is associated with a rare risk of a brain infection called PML and requires monitoring. Here are the rest of them. The 3 orals came out starting in 2010, Gilenya, Aubagio, and Tecfidera. They work in very different ways. All of them are different from each other. And I would say Gilenya and Tecfidera tend to sort of have the edge as far as overall effectiveness. Aubagio is also quite effective, however, and very well tolerated. They each have different kinds of risks and require a certain amount of monitoring, lab monitoring, and risk assessment. Plegridy is a long-acting form of interferon beta that's every couple of weeks. Limtrada came out in 2014. It's an annual infusion, 5 days in a row, and then you're done for the year. Very, very powerful. It's probably our biggest medication and has some very interesting data as far as long-term outcomes. There's some safety concerns. I don't use it as a first-line medication, however, but have had a lot of success in our limited clinical experience. Zenbrida came out in 2016, very novel concept in the immune system, not thought to actually be immune suppressive. And then last but not least, this new medication, Ocrevus, that just came out at the end of March of 2017, the first medicine ever approved for primary progressive multiple sclerosis, which is tremendous, a tremendous advance, and tremendously powerful also for relapsing remitting MS. I'll talk a little bit more about that drug in a second. Oh, right now. Okay, so Ocrevus, first medication to show significant benefit in primary progressive MS. They studied 720 patients were enrolled in the trial, and the medicine is given every 6 months, over 2.5 years. There was a 25% decrease in disability progression compared to the placebo group, and the MRIs also showed a significant improvement. I can talk a little bit more about it. So it's very similar to a medication called Rituxan, which we've used off-label for several years. It affects something called B lymphocytes, which is part of the immune system. It's thought to be a little less allergenic. People tolerate the infusions a little bit better with Ocrevus than they did with Rituxan. There is some concern about a slightly higher risk of infection seen in the trials compared to the control groups. There's some concern maybe about a slightly increased risk of breast cancer in women. That's not clear. It's not clear if that's real versus a statistical anomaly, and that's being watched very, very closely. But mammography is recommended. There is a theoretical risk of PML because there has been PML that's the rare brain infection. There has been some PML with Rituxan. So those are some things to be mindful of with Ocrevus. But it's very convenient if you're on it. It's only an infusion every 6 months. What about the future? We've talked about the things that are available now. Saponamide in secondary progressive MS. This medication is expected to be approved probably this year. So let me tell you, and this will be really one of the first, actually Novantrin had a label, I think, for secondary progressive MS, but there's really not a lot out there, right, for secondary progressive MS. So in this clinical trial, 1,651 people with secondary progressive MS were enrolled, placebo arm, compared to treatment arm, very long study duration, 5 years. That's sometimes what you need actually to detect these differences in progressive forms of MS. There was a 21% decrease risk of disability progression with saponamide. It's an oral agent, similar in many ways to Gilenya as far as the mechanism of action, but not identical, and probably with some advantages. So that is exciting. That is very, very exciting. And likely a medication that I will be happy to use on certain people. What about lipoic acid in secondary progressive MS? It's lipoic acid. This is available over the counter. It's a very potent antioxidant. And there's evidence in the mouse model of multiple sclerosis that it can really improve things. In a 2-year study, in humans, however, 1,200 high dose milligrams of lipoic acid was given, and there was a placebo group, and there had 51 patients, so it's a much smaller study with secondary progressive MS. And in the lipoic acid group, there was a very significant reduction in brain atrophy. That's really impressive, actually, to have that kind of outcome compared to placebo, and a larger study is now being planned. Has anyone heard of this one, Clemastine? This was in the news over the past year. This is, again, stuff on the horizon, stuff to just know the word, because you may see some of this stuff come to fruition in the next 5 years. This is out of UCSF in San Francisco. This is an over-the-counter antihistamine, actually, but it's been identified to be a potent remyelination compound in cell cultures, and has also, so then they did it first in cell cultures, then they applied it to a mouse model of MS, and it showed significant promise there, and human trials are being planned. So, remyelination is really the holy grail, right, of MS care. And this is a very novel thing. What about stem cells? I'll just briefly talk about that. There was a lot of news last year about stem cells in multiple sclerosis. Just by way of review, a stem cell is a single cell that can replicate itself or differentiate into different cell types, like red blood cells, muscle cells, or nerve cells. Stem cells can come from yourself, and if it's harvested from yourself, from your own bone marrow or blood or fat, they call it autologous. Or if it's allogeneic, it's from a donor. Those are what those words mean. If it comes from the blood or bone marrow, we call it hematopoietic, or mesenchymal comes from bone marrow or fat. These are words that are thrown around a lot in the layman literature and certainly in the scientific literature, and it can get very confusing very fast. But there were some real advances last year I'll briefly touch on. This is the Northwestern Stem Cell Study. This is the paper that came out, and there were 151 patients with multiple sclerosis, relapsing, remitting, and secondary progressive that were given high-dose chemotherapy, and they got autologous, so the stem cells came from themselves, hematopoietic stem cells, and they were delivered IV one time. 64% of this group were followed, the group was followed, and 4 years later, 64% had improvement in disability. So it's not only that they didn't get worse or stay the same, 64% improved. However, in the progressive MS group, there was no benefit. Nobody died, which is good, and unfortunately you have to note that when you think about stem cell studies, because it's a very risky thing to do, to ablate someone's immune system. So it's a very promising treatment for highly active, relapsing, remitting MS, and more randomized trials are needed. Another big study came out last year. This was a big splash out of Canada, where they did full immune ablation. So they ablated people's immune system, and then they did another autologous transplantation, so from self, of blood-derived stem cells. Smaller study, only 24 patients, very highly active MS. One patient, there was one fatality, unfortunately, related to that immune ablation. However, 70% of the group had no further progression of disability after treatment at 6 years on average. It's incredible. 70% of people got no worse at all. So it really, the majority of people just arrested it. And again, this is highly active relapsing MS. And also the rates of brain atrophy are similar to people who don't even have MS. Healthy volunteers. So it really slowed down the damage dramatically. And about 35% had improvement in disability scores, actually got better. So again, very promising, very similar approach to Northwestern, but with some significant risk. And again, that's in relapsing MS. This is a study I'll briefly mention. It's Dr. Sadiq up in New York City, stem cell study he's starting. He has 20 patients. These are all in progressive forms of MS. And I know for a lot of people in this room, that's what they're interested in, right? We have limited treatments, more and more all the time, but limited. So these are derived from self, autologous, but they're fat or bone marrow derived. They're different cells. They're mesenchymal cells. And they're processed, they're withdrawn from the patient, processed in a very special way, and they're injected by spinal tap 30 minutes later, which is something that's very novel, to be able to re-deliver the cells right away. And these patients were treated with a total of about 3 doses 3 months apart, and so they reported that there were no serious adverse events. There's some limited effectiveness data that shows some improvement in some in phase 2 trials are underway. And this was presented in April, about a year ago, at the American Academy of Neurology. So we're hoping that not only is it safe, but that it's effective, but we really don't know quite yet. So there are still a lot of unresolved questions, and people talk about stem cell a lot, right? So we don't know exactly what type works best. Is it the mesenchymal? Is it the hematopoietic? Is it from self or from other? How quickly should the cells be processed before it's re-injected into the patient? What type of MS can be treated successfully? Is it relapsing only, or can progressive MS be treated? What's the best route? Should it be given intravenous? Should it be given through a spinal tap? All of these are being tried right now. What's the right dose? How many stem cells do you need? And do you have to even ablate the immune system or not? Or is it just the act of ablating the immune system that derives all the benefit? So these are unresolved questions. So there still needs to be a lot of research, but there is real progress, and I think there's real reason to be hopeful. This is an article from the New England Journal of Medicine from last year called describing sort of a really unfortunate story of a man who got stem cells in another country and developed a tumor. I think he had a stroke, and he went to China and got a variety of different stem cell therapies, and then ended up with a tumor that was stem cell tissue that had formed into a tumor. It wasn't his own tissue. So we call it stem cell tourism, and unfortunately there are some unethical places even in this country today, and certainly outside the US, where they prey on people's desperation and say, hey, we do stem cells. But I just tried to kind of alert you to the fact we have so many unanswered questions. No one can really say we do stem cells and we know what works for MS. No one can say that yet because we just don't. And so I have some patients that have gone and spent a lot of money on stem cell therapy. And it's all very well intended, you know. I understand it completely, but I'm concerned that it may be a waste of money at least, and sometimes it could be a health risk. So like I say here, the biggest risk is that you may waste your money for therapies that are just unproven. We don't know if they work yet. Insurance doesn't pay for stem cell therapy yet because it's unproven. Once this kind of stuff gets proven, like it is for lymphoma and leukemia specifically, really, insurance will pay. But we have to have a certain level of evidence for that to happen. There's a small but real risk of malignancy if embryonic stem cells are used, and it's unregulated by the FDA. So this is just a word of caution. So the advances in stem cell research in MS are real and exciting. In highly active relapsing MS, the evidence of benefit is strong, but the risks are still high. In progressive MS, there's some promising benefit, but be cautious and be skeptical if stem cells are being done outside of a clinical trial. And you can always look, if there's a study that you're interested in, always check it out on clinicaltrials.gov to make sure it's a legitimate research trial. All right, and finally, just a few words about wellness. Vitamin D, I talk a lot about vitamin D. We understand that vitamin D shifts the immune system, kind of like Copaxone, quite frankly, and interferon. So sun exposure is an effective way to increase your vitamin D level, but too much sun, can be a problem too. But, you can definitely get some sun to boost your vitamin D level. Very briefly, this is a study where patients took either 800 international units a day of D3 or 10,400 over 6 months. And in this study, it showed that the bad Th17 cells, bad cells at MS, were significantly reduced in the high-dose vitamin D. So this was just very good biological evidence that in MS patients, high doses of vitamin D are basically immune therapy. That's what I think of it as. And this was published in December of 2015, about a year and a half ago. Another study from the University of Cambridge showed that vitamin D is actually integral to myelin repair. So beyond just immune changes. It can help with remyelination. And so in general, we think that vitamin D makes MS better. I won't go through these last few studies, but there's lots of seroepidemiology, and there are some clinical trials still ongoing looking at this. So we recommend that patients take between 3,000 and 5,000 units a day. But the most important thing is really to check your level, which we do about once a year at least on patients. And we like the level to be above 55, between like 55 and 80. Diet, there's no need for me to talk too much about this because it was covered so eloquently earlier. I recommend a whole foods diet too, low in saturated fat. There's abundant evidence that that's probably the way to go. There's tons of interesting research going on the gut microbiome. Has anyone even heard of the gut microbiome? Anybody even know what I'm talking about? Really? No one? No? You do. Okay, good. So the idea of the gut microbiome it's the study of, well, it's the fact that we have lots of good bacteria inside of our intestines, and we need it there. And there's certain theories of autoimmunity that this gets so disrupted over the course of our lives of eating white processed food, tons of sugar, and having courses and courses of antibiotics that all this good bacteria gets wiped out, and there's a lot of imbalance in our GI systems that can lead to autoimmunity. So this is an article from Nature Communications. There's a lot of papers coming out looking at abnormalities in the gut microbiome, in the gut bacteria of people living with MS. So this is a very hot new area of research. This is just a picture of Dr. Sergio Baronzini receiving the 2015 Rheingold Award from the MS Society for the most outstanding research proposal. And what he said in that acceptance speech is, "My vision is that one day we will be able to combine genetic and microbiome data for a given patient that doctors will use to prescribe a specific diet, probiotic, antibiotic, to more effectively reduce the incidence, severity, and progression of MS." I love this idea because it's more intelligent, really. It's talking about tolerance. We need to, autoimmunity is intolerance to self. We need to create tolerance to self. Right now, the big approach in MS is just to suppress the immune system, at least with the drugs that are coming out. But if we can just teach it to love itself again, stop fighting. And I think that these approaches are really getting to the core of the issues. So I find this stuff super exciting. Exercise in MS. There's lots of published research on the benefit of exercise and physical activity in MS. We know that exercise leads to better cardiovascular fitness, improved strength, better bladder and bowel function, less fatigue and depression, a more positive attitude, and increased participation in social activities. Here's an abstract from the AAN. Aerobic exercise improves fitness and cognitive performance in relapsing MS. And people can do a variety of different things. Swimming is one of the very best things you can do if you have multiple sclerosis because it keeps the core temperature down. But even if people are in a wheelchair, they can participate in fun activities, even road races and that kind of thing. MS yoga is also tremendously invigorating and has a meditation component, and stretching is a wonderful thing. And this is an example of people just being active in the home, gardening, cleaning, walking up and down stairs, cooking with friends. This is being active too and engaged. Also important, and moving your body, like having fun. So how do you start exercising? Well, sometimes people might feel this is daunting. I really don't exercise. How do I get started? Well, your MS care provider can start physical therapy, and sometimes that's a good first step to do it in a supervised environment with a professional. MS yoga. So at Ochsner, we offer MS yoga, and you don't have to be a patient in our clinic to go. It's twice a week. But if you want more information, you can talk to me after. And then there's MS Aquatherapy at East Jefferson Wellness Center. So there are some things in our city, in our greater New Orleans area, that can help people get moving, get started. Mindfulness. What about that? Another abstract from the meeting last year, telehealth mindfulness meditation improves cognitive performance in adults with MS. So this is evidence that mindfulness meditation can actually improve your thinking. And there was a study, I won't get into it, but basically the bottom line is that it helped people think and remember better. How do you achieve that? Again, yoga, meditation, you can do it yourself. There's apps that you can get to help with mindfulness and meditation. There's all this evidence that meditation is it's not only good for MS, it's good for all of us in our busy lives with our cell phones and all the pinging and binging that goes on in our lives. And it's good for people with MS too, and especially. And I think that's it, actually. So thank you. And if you have any questions, I'm happy to take some.
Let's thank Dr. Bagert first. All right. So what I said before, I'm going to need you to raise your hands, and I'm going to run around the room. I have avocados to get rid of, okay? So, yes, I see you all the way in the back, but I'm going to start over here and make my way, because these legs got MS too, you know? You're first.
Hi, I just wanted to know, what is the difference between relapsing MS and progressive MS? I've never heard of progressive.
Okay.
So,
Yeah.
I have relapsing.
Right. Good question. Important question. So relapsing MS is the form of MS that's typically diagnosed at the beginning, not for everyone, but for most people, and it's when they experience sudden episodes of loss of function. So it might be optic neuritis, where people go blind, or double vision, or maybe suddenly a person becomes numb on one side or weak in both legs, and it's sudden. And it gets worse, usually over hours or days, and then it usually gets better, either on its own or with steroids, the help of steroids. Often people have to go to the hospital. And so that's what a relapse is. And when people have that pattern and then it happens again over time and again, that's called relapsing remitting MS. Progressive MS is when that pattern stops. If someone starts with the relapses but then no longer has relapses but finds that year after year they're losing more and more function, that's called secondary progressive MS. It's secondary to the relapsing. They no longer have the relapse events, but they're losing function. And then there's primary progressive MS, which is when people really never have relapses, like I was describing. No sudden episodes, but there's just a slow progression and accumulation of disability from the start without relapses.
The things you described are what I have and how I feel a lot of the times, and I can feel a relapse coming on with the numbness and tingling and what have you.
Yeah.
But most of the time, I've only been back to the hospital 3 times.
Yes.
But most of the time, after a day or two of resting, and I feel better.
Good.
So that's, the doctor still says it's relapsing.
Right. Okay. It doesn't sound like it.
With secondary progressive, should you go ahead and start that new medicine coming out, or should you just wait for that other one you were talking about that should be out this year?
The one that's coming out later in the year, Saponamide.
Should you just wait or go ahead and take that one?
Well, that's a good question. That's a very individual question. I can tell you frankly, I am open to using both of them.
So I'm going to do that one, then do the other one when it comes out.
Right.
Okay, got it.
Any questions over here while I'm here? None here? Gotta watch that cane, almost tripped. Wants to run?
Wait until you get over there.
Yes.
How you doing?
Good.
I wanted to ask, I heard you said people with MS should be taking vitamin D.
Yeah.
Okay. I was on vitamin D.
Yeah.
I'm not on it anymore.
Right.
Should I talk to my neurologist about getting back on vitamin D?
I would recommend it. You know, one of the things I've found is sometimes primary care doctors will take our patients off vitamin D because for people who don't have MS, the recommendations for vitamin D supplementation are very different. So for just general population, it's not clear that people really need to be on vitamin D. Or if they're low, yeah, but if their levels are in the low normal range and you don't have MS, it's not clear that you need to supplement. But if you have MS, it's very different, and a lot of the primary cares aren't aware of that data and that kind of thing. So sometimes we'll hear a story like that and we'll get patients back. It's always good to get a level drawn, to get a blood test, to kind of know where you start, and then you can tailor the vitamin D dose appropriately, and your doctor should be able to do that for you. Thank you. Welcome.
Hi, how you doing? During the speech, you talked about Clemastine.
Yes.
And the potential of that being like assisted with remyelinating, right?
Potentially.
Is it something that you would recommend?
No.
Not at all?
No.
Only in the studies?
Only in the, yeah, it's very, very early in the clinical research. And I'm telling you about it because it's interesting and promising. It's great that there are so many agents for remyelination on the horizon, and that was sort of the objective. But I wouldn't recommend it because it really needs to be studied in humans a lot more to see if these kind of doses, because they're higher doses than you would normally take over the counter, and to see what the risk-benefit ratio is. It may be really worse for you than better. We don't know. Yeah.
Over here. I have a question for you.
Yeah.
And that is when a patient comes in to see you for the first time, and they come with the family, and they really don't know much about multiple sclerosis, how do you educate the family on what is happening, and how do you come up with what you're going to decide on as the best medication for that person and their lifestyle?
It's a good question. So I often ask the patient and their families what they know. Do they come with any preconceived ideas about what MS is and what can be done? And often, you know, often people are very well educated, and sometimes they're really not, and sometimes people are really afraid. It really varies tremendously, but sometimes people present with a lot of fear and not a lot of information about wheelchairs in the future, and I'm not going to be able to work, and so I get the gamut. But I do try to solicit the patient and the family about their knowledge and expectations, and then I'll explain that MS is treatable, highly treatable, and that what it is an imbalance in the immune system, and that our goal is to get the immune system back to balance so that the brain and spinal cord won't be damaged anymore in the future. And our goal is to prevent disability, and we talk about how medication is our primary way of doing it, but also lifestyle, vitamin D, wellness, nutrition are part of the story too. So we'll talk all about that. As far as picking the medication, what I do is, what I don't do is go through all 15 because I feel that becomes unfeasible. It's not feasible. And I do ask patients, you know, what are your goals? Are you risk averse? Are you sort of more open to taking risks? Those sort of questions matter. And then I paint the landscape of the different medications as far as there's the milder medications, not quite as powerful. They might work for you or not. And these are the risks, and I go all the way up basically to the more higher risk medications. But I might not present all options to all patients. I try to kind of keep it contained to some extent. Now that said, if someone comes to me newly diagnosed and moderately disabled, I will definitely jump up to bigger medication. I won't start with the mild stuff.
Great, thank you.
Yeah.
So I have a question. I hear you talking a lot about prescription therapies and stuff.
Yeah.
What do you feel about like alternative therapies, like herbs and vitamins and stuff like that?
Well, so I think a lot about that kind of stuff. So for example, I mentioned lipoic acid. That's an over-the-counter supplement that's been around for years. And however, it's been now studied in a rigorous manner, in a way that helps us truly understand whether or not it works for MS. And so that's where the rubber meets the road. You know, if it's not studied, then I have a hard time knowing if it works, because I believe in science. I believe in science. That doesn't mean we have to abandon our intuition and our humanness, but I believe in science at the end of the day. So there are a lot of places around the country and all over Europe where they take herbs and vitamins and supplements and study them. I actually trained at Oregon Health and Science University, did my fellowship there, and I studied ginkgo, which is an herb. But I studied it in a rigorous way, which is validated, and guess what? It doesn't work. And now we know that. And so people don't have to waste their money on ginkgo. Let's do other things that actually do work. So sometimes they don't work. A lot of times they don't, and a lot of times they do. It's just a lot, you know. So I believe in science, but I'm very open to it.
Next question.
Actually, I have two questions. First question is, most people who are experiencing MS, do they have brain lesions, or are they mostly spinal tap? What is the most diagnosed?
Oh, so most people have lesions in the brain and/or spine. Not everyone gets a spinal tap. Sometimes it's easy to arrive at a diagnosis without a spinal tap. It's not required necessarily to achieve that diagnosis. But in some people, depending on the other kind of evidence, we need it. So, but almost everyone has brain lesions, but not everyone has spinal taps done. And not everybody with multiple sclerosis has an abnormal spinal tap. About 90% do, but about 10% have MS and have a normal spinal tap.
Gotcha. And I read something recently that color blindness could be a symptom of MS.
Well, my understanding is that it's a symptom of having had optic neuritis that you didn't know that a person might not have known about. I don't think I'm not aware at least that being born colorblind is a predictor or a risk factor for later developing MS. Is that what you mean?
I'm talking more about developing, like you could be born with
Normal.
being able, right,
Yeah.
but then you develop color blindness.
Yeah.
So is that like a red flag to maybe think,
Yeah. Yeah.
And I say this
I think
because
so.
I have MS,
Yeah.
obviously, and back in the day when I was in my 40s, I was diagnosed with being colorblind.
Oh,
It's
that's
like
interesting.
and then all of a sudden, then now I'm noticing my daughter is starting to see some variations between shades.
Mm-hmm.
So I didn't know if that was something that maybe at this point, is that something we should be looking into right now?
Well, I
or?
might have her see the ophthalmologist, and you can do color testing for sure. There are these color plates that you can go through right away to actually see if someone's colorblind or not. So that might be a non-threatening but pretty effective way to actually determine whether or not she's colorblind.
Perfect. Thank you.
Yeah.
Any other questions over here? Any down there? Good, because I got another one to ask. So going back to when, people come in, and MS is known to attack the families, right? So it's not just an individual having MS, but everybody in the family is affected by this. Does your office encourage that maybe a patient, when they come in, bring a family member, just so that way they can have help in remembering things?
You know, that's a great point. And I don't think we have an active policy of doing that, but we probably should do that. I think we find that a lot of people come with family naturally, but not everybody does. And so that would be a really great suggestion.
True. And
Yeah.
do you ever get caregivers helping to make a decision on what the person in the family with MS, but the caregivers helping to say, hey, maybe if this is going to affect you, make you feel flu-like, maybe that you really should look into doing something else, or maybe, using something that won't cause any, much of a reaction at all. Do you ever get any caregivers to actually take part in the conversations?
Definitely, yes. I think so. I think I encourage caregiver participation for sure. But then at the end of the day, I always remind the patient that it's their decision in the end. But it's always a great discussion when the caregiver has input and everybody listens, including me. And I say something and I'm heard and it's processed. But at the end of the day, when the patient gets to make the decision, I've heard over the years so many times, that doctor gave me 5 different boxes of medication choices and sent me home. And I have such empathy for those patients, because that's not shared decision making. That's like, relinquishing responsibility for the decision. That's too much, right? Has anyone ever experienced that over the years where you felt like there wasn't enough interaction? So that's too far, but I think there should be a healthy balance of participation of everyone. And if there is an invested, loving care family member there, then that participation is welcomed.
Thank you. Also, there's a lot of patients, and I don't know if there are any here or not, but I'm just saying in general, there are a lot of patients that just feel that, hey, I really don't want to do any of these meds. I mean, I don't feel like feeling crappy at the end of the day or afterwards. I don't want to spend time doing an infusion. I don't want to do a pill because I don't think I'm going to remember it. What do you do to encourage those people that they really should be using something?
So what I usually talk about is we have a lot of data from the era of when people did not have MS medication. And so we call them natural history studies. And there's all this very powerful data about people, for example, who had relapsing remitting MS for years and had, maybe relapses, but it would just be managed. And then 10, 20, 30 years go by, and then they start limping. And then they're in a scooter, and then they're in a power chair. And that's what we're trying to avoid in the people who have milder relapsing remitting MS in their 20s and 30s. We're trying to preserve their independence and their function in their 50s, 60s, and 70s. And boy, talk about delayed gratification. That's a story that you really have to tell and convince people like it's worth investing in your health now. But at least we have the data to back it up. And then, for other people who have more severe MS, sometimes they need less convincing. But for the people who have mild MS early on and they're not becoming disabled but having a lot of relapses, sometimes it does take some convincing.
Great. Thank you for that. By the way, I'm sure everybody in this room brushes their teeth, right? And you do it because you don't want to have to visit the dentist, right? So the same thing applies to what the doctor was just talking about. You don't want your MS to worsen, so you should be taking a medication. Okay? Another question.
So I just want to know, what is your opinion? I know they don't use Navantrone much because of the risk of leukemia. Yeah. So I was on 6 months of chemo, and I opted to use Cytoxan instead of Navantrone because of the leukemia risk.
Yeah.
What is your opinion about having to take MS medications after you've done a 6-month round of chemotherapy? Because it seems like it kind of reset my immune system.
Yeah.
What is your opinion about that?
So I've had a few patients like that, and what I typically do is put them on something like Copaxone or Avonex or something like that afterwards, where it's not suppressing the immune system, give their immune system a break. And you're right, I often find that kind of therapy does reset. And in fact, since you brought it up, there is all sorts of data that Cytoxan, which is chemo, can be beneficial in kind of earlier forms of progressive MS. In fact, I saw my last patient of the day today. We were talking about that very thing, just thinking about that.
Yeah, it really did well for me. I mean, my doctor wanted me to take a Bagert, but I'm kind of like not really liking that because, I just haven't had any problems since I finished the chemo.
Yeah. So I think it's very important. I don't know, I might do something that's not immune suppressive. That's a little bit more of an insurance policy. And I think it's just very important to go to the doctor, get your tests, get your clinical exam, get your MRIs. But I would probably do some platform injection probably.
Any other questions here? Great. Otherwise, I had another one.
Dr. Bagert, could you tell me maybe the benefit or the disadvantage of pregnancy for folks who are interested in having babies with MS?
Yeah. So the rule in general is that pregnancy is a protective state. And the reason for that may be in part hormonal, but for sure it's because pregnant women become immune suppressed, right? And there's nothing like immune suppression to help MS in the short term, right? So that foreign baby inside the womb, it would be something that a mom might reject if the immune system were fully intact. But all pregnant women become immune suppressed very quickly so that we don't reject the baby, and that's good for MS. Now, of course, with every rule, there are exceptions, and we've seen them in our clinic for sure. So sometimes it doesn't work that way, and people actually there's something about the process that activates the MS, and we see that, but that is rare. And so from just an immune system point of view, it's generally a protective state. Beyond that, it becomes a very individual decision. If someone is extremely disabled and can't care for themselves, it might not be the wisest choice to have a baby. But again, that's very individual.
Question from the back of the room.
Dr. Bagert, is there not thoughts or a way of having the body mimic pregnancy then?
There are, in fact. And so there's been all sorts of data coming out of UCLA using estriol, which is the form of estrogen that rises sky high in pregnancy. And that was promising. That data's been very, very promising, but I don't think quite as revolutionary as everyone hoped for. So it's still not really standard of care. And my sense of the biology is that it has less to do with that and more to do with the immune suppression. And I don't think that estrogen causes immune suppression. It's just a pregnancy hormone. So I suspect it has more to do with the immune suppression of pregnancy, which, effectively we do that with all the meds. Yeah.
Any questions over here? I'll be there in a minute. I'll be there in a minute. So I have another question for you, and that is that what do you do and what do you talk to the families or the patients about when it concerns just mobility? How can they help themselves to be able to move better?
Yeah, so multifactorial. Certainly if we recommend a lot of rehab and physical therapy. I'm constantly handing out our MS yoga cards to we've got these 2 MS yoga classes now. The second one hasn't started yet. If any of you guys attend our classes, we're opening a class on Tuesday. So we encourage them to go to yoga. We encourage them to go to physical therapy or our aquatherapy class at East Jefferson. It's not our class, but there's an aquatherapy class for MS. So we encourage those sort of small steps. If a person's overweight, we talk about that because, again, being overweight with immobility just makes everything harder. Transfers are harder, exercising is harder. And so we might refer them to our medical fitness program or a nutritionist to try to help with that process. Sometimes there's medication we may use, like Impera, which can help speed the conduction along demyelinated nerves. And so we use that often in our patients with mobility problems. If, for example, a person might walk well except they have a bad knee or but they've been putting off that knee replacement, I encourage them, go get that knee replaced, man, and get moving again. Don't put that off. Let's get moving again. Or if they need maybe an ankle foot orthotic brace, sometimes just the littlest adjustment in a person's gait can make all the difference in the world, and then a patient can save energy. If a patient needs a cane or a walker to be safer, to prevent falls, and to preserve their precious energy, we'll encourage that too. So it's very individual.
Thank you for that answer.
Yeah.
You're next.
When you were talking about the gut microbiome, do you think probiotics is something that a person with MS should take?
So I don't routinely recommend it because I don't know which one to recommend. I predict, like I sort of alluded to, that in the not so distant future, we're going to be recommending something. I think, again, that's going to be an individualized thing. Quite frankly, I think people are going to give stool samples, send it to a lab, figure out where they're deficient, and then they'll have individualized prescriptions on what to take.
Oh, I did have one other question. Getting back to the pregnancy story, because my daughter has MS and I'm concerned, I'm going to take these answers back to her. Should she consider stopping her treatment before? I mean, if they're considering having a baby, should she just stop ahead of time and talk to a neurologist about that?
It really depends on the medicine.
Okay.
Yeah, it really depends on the medicine. There's some medicines that need to be stopped under a lot of supervision. Sometimes you have to give pulse steroids. It just depends. But in general, I don't recommend people being on medication during pregnancy.
Any question? Oh, there we go. Good. I need to run around. Remember that.
You were talking about MS and exercise and what have you, walking, knees and all. I had the knee replacement, and I had it done by the doctor. Everybody who said, "Oh, he's the best. You know, you're gonna be in great shape."
Yeah. No, bad outcome. It didn't work out, huh?
Did not work out for
Sorry.
me, and I am still having problems.
Oh.
And where the doctor says, "Well, it must be your MS,"
Okay.
and I'm like, I don't think so.
Yeah. Well, it's always good to advocate for yourself and maybe get some other opinions from different orthopedists and see. And have you done lots of physical therapy? You done all the rehab? Well, maybe it's worth getting a second opinion from someone else. I always encourage people to do that.
Question from the back of the room?
You talked about possibly finding something that would dictate a probiotic for people.
Mm-hmm.
It sounds sort of like a biomarker. Is there some kind of biomarker for MS?
That's a great question. So there's no litmus test for MS. I mean, you could argue that oligoclonal bands in the spinal fluid, the MS profile that we look at, is a form of a biomarker. You know, if I can be technical, an MRI is a form of a biomarker for multiple sclerosis. But no, as far as I know, and as far as the literature suggests, there's no particular absence or imbalance in the gut microbiome that's a signature yet for MS, but this is so new. I mean, we don't know. This is just the beginning that people are starting to report their research on this stuff. It's very new. So maybe we'll find that. Maybe we'll find that in multiple sclerosis there's a signature pattern of abnormalities.
But is that going to then dictate which medication might be the best for a patient?
I think that's hard to speculate on because we don't even know whether or not there'll be a signature. It might influence what probiotic or what remedy, whatever form that takes, a person might undergo to get their gut back into gut health.
Okay. Any questions? Front, exactly. Front row.
Doctor, a question that I heard of something so long ago.
Okay.
People in England were doing pot to help relieve the spasms in their back.
Yeah.
What do you think of that?
I think it's probably true.
I'm so full of spasms,
Mm-hmm. No, I mean, there's abundant evidence that THC, which is the active compound in marijuana, can help spasticity specifically and pain. The pain of spasticity, because spasticity is painful. And boy, that back spasm in MS is such a common thing. In our clinic, we actually inject those paraspinal muscles with Botox to help relieve the spasms. So that's one thing that we do. But, medical marijuana is coming to Louisiana, and I do believe that it can help with spasticity. Now, there's other data, that if people with MS have cognitive dysfunction, which is common to begin with, that can get worse on marijuana. And so it's not like I advocate that everyone should go out and do this all the time, but I do believe that there is some effectiveness with the spasticity management.
Since you brought up about marijuana, what about CBD oil?
Yeah, I'm okay with it. A lot of people are starting to do that, and I never discourage it because I think the data is kind of promising. I don't know a ton about it, but I know it's related to THC.
For those that don't know, the CBD oil is hemp, which is like decaffeinated marijuana plants. Okay, it's without the THC, and it's just where they extract the oils, and so that you're relieving your spasticity or the pain in your body without getting high. Okay, which is what a lot of people do encourage, so that you're not walking around and adding to your cognitive issues. Right. Do you have anything more to say about that?
Well, no, except that I think this is an area that is interesting and promising and should be studied more, so that we can enthusiastically recommend certain things, without being all like hedgy about it and scared we're going to make people do the wrong thing, or cause more problems than benefit. But it sounds very promising to me.
Great. Any other questions? If not, I'm going to let the doctor off the hook, or I could grill her all night. Thank you, everybody. And thank you for doing this. I'm sure they got quite educated here tonight. This is great. All right. And again, we want to thank Teva for providing us the grant that we could do tonight's program, okay? And again, we cannot do these programs that we do in 21 states right now. 21 states we're doing programs in this year. And yes, that's me running around the country doing these things and running around rooms getting questions and answers, and then also me picking on the speakers and the questions that I have for them. So, you know, fill it out. We want to come back to New Orleans, whatever you want to call it. We want to come back to this area. We want to see what you have to say about tonight's program. And again, thank you for coming, and drive home safely.